Hello, everyone. Welcome. So as you just heard, we are going to be recording this session. Thank you all so much for joining us today. I'm Jenny Epstein, Deputy Director for the Office of Policy Planning and Statistics at the Illinois Department of Public Health. We want to welcome you all. I know people are joining, so I'm going to wait like a minute before we get started as I see the number creeping up on our attendee tally. Just confirm if I could get maybe a thumbs up to make sure everyone can hear me. Great, okay. We're just gonna wait a couple minutes. I know people are often jumping from meeting to meeting. Okay, I'm going to open us up. So again, welcome everyone. Thank you so much for joining us for a presentation on the Illinois Homelessness, Mortality, and Morbidity Report for years 2017 to 2022. On behalf of the Illinois Department of Public Health, I'm happy to welcome you today to hear a presentation from our esteemed colleagues, Dr. Lee Friedman and Dr. Dana Madigan from the School of Public Health at the University of Illinois, Chicago. We'll also be hearing from, at the start of the presentation, from Colleen Mahoney, our Senior Policy Advisor, working with IDPH on behalf of the Illinois Office to Prevent and End Homelessness. Next slide, please. Okay, looks like some people, is anyone else having audio issues? I'm seeing there's someone having audio issues, but it seems like everyone else is okay. Great. As we start today, I do want to ask if you wouldn't mind, please putting your name and affiliation in the chat box. It just allows us to kind of see who the audience is and making sure that we did the right outreach to get the right people on today's call. So we really appreciate that. Thank you so much, Catherine. I saw that you put, people are adding it. Thanks so much. So quick agenda. We did welcome introduction, so I always like to check things off the list, so that's really great. We can check that one. We're going to do report overview, so we're going to hear from our colleagues at the University of Illinois School of Public Health on the analysis of the mortality and morbidity data. And what's really important is we're going to have a pretty ample opportunity to have questions and answer period. So really appreciate any questions you all have, feedback, and really looking forward to a really vibrant conversation about this report. Next slide. Just want to do some quick acknowledgements. I want to thank our team at the Illinois Department of Public Health. So this effort was, the leaders at the department really came from our director, Dr. Vora. We have our partnership, and also Amanda Fogelman, who's on the call, our division chief for the Division of Health Data and Policy. And then there's too many to mention, but their names will be in the report, all of the dedicated data stewards that we have at the Illinois Department of Public Health that worked with our partners at UIC to make sure that we had the right data to really bring to light the important issues that are gathered in this report. I want to thank our colleagues at the University of Illinois, Chicago. So we have Dr. Friedman and Dr. Madigan on the call. Also the partnership that we had with the Institute for Healthcare Delivery and Design really helped us a lot to move this work forward. And then finally, I want to thank the Illinois Office to Prevent and End Homelessness, Chief Christine Haley. We're lucky to have Colleen Mahoney as our Senior Policy Advisor here, and all the efforts that they have put forth, which you'll hear about in a little bit on Home Illinois. So with that, I'm going to have Colleen take over to give a little bit of background. Oh, sorry, the vision of IDPH. I won't spend too much on this. I forgot we had this slide. IDPH vision, I think this report is really an example of that, to really empower and support Illinoisans to achieve their optimal health with dignity and acceptance in diverse and thriving communities. and to be a partner and advocate with the people of Illinois to re-envision health policies, promote health equity, prevent and protect against disease and injury, and prepare for health emergencies. That's why we're all here today. And I think the Home Illinois Plan is really a great example of that. And I'll have Colleen go.
Wonderful. Thank you, Jenny. So before we dive into the report, we want to give you all a little bit of context on Home Illinois, which this report is a part of. So I want to give you a little bit of information about that larger initiative, and then some additional context about this morbidity and mortality report and how we're thinking about it moving forward. So this report is a part of IDPH's participation in Home Illinois, which is the state of Illinois' interagency strategic plan to prevent and end homelessness across our state. We understand that homelessness is driven by many things and affects many facets of folks' lives and is driven by many systems. And so many state agencies have a role to play in preventing and ending homelessness, including IDPH. So Home Illinois, as a strategic plan and an across-department initiative, is supported by the statewide Office to Prevent and End Homelessness, or OPA. And both of this kind of initiative and the office that supports it, as well as the task force, the interagency task force that many departments such as IDPH participate in, were established through an executive order signed by Governor Pritzker in September of 2021. And then just last year in July of 2023, this framework of the interagency task force, the OPA office, were codified into law, so to make sure to preserve the framework that was established by that executive order. And if you want to learn more about Home Illinois generally and OPA and all of the participating agencies' work, you can go to endhomelessness.illinois.gov. Home Illinois, the work is organized by a strategic plan that comes out every 2 years. So the first plan was released in the summer of 2022, and a new plan will be released this summer. The plan documents commitments across about 17 state agencies and contains more than 100 policy, program, and process activities tied directly to homelessness that the state is taking on. And in FY24, Home Illinois had a budget kind of across many programs of $200 million, of over $200 million. And this year in FY25, the budget is over $290 million. A lot of that increase going to emergency court-based rental assistance. So this is a priority of the governor's office and of the state of Illinois, and IDPH is really excited to play a part in it. Want to tell you a little bit about the framework of Home Illinois overall, and then how this report fits into it. So the Home Illinois plan, if you look at it, you'll see that it's organized. It's infused with an understanding that racial equity has to be incorporated into all the activities of the plan. We understand that there is a huge racial disparity that exists in homelessness right now, and who's at risk of homelessness. Black Illinoisans are 8 times more likely to experience homelessness statewide than white Illinoisans. This is actually the second highest state disparity rate in the country. Nationally, the rate is about Black Americans are about 4 times more likely to experience homelessness than white Americans, and in Illinois, our rate is twice that. So that understanding of racial equity has to infuse, all of our work. And then with that foundation, the 4 pillars that organize the activities of the plan are building affordable and permanent supportive housing, bolstering safety net systems, securing financial stability for low-income households, and working to close the mortality gap that exists between people experiencing homelessness and the rest of our state's population. So I encourage everyone to look at the plan, to learn more about that, and then to look at, if you want to learn more about kind of racial disparities for Black Illinoisans within homelessness, to look more at a recent report, Black homelessness in Illinois, structural drivers of inequity, which you can also find linked on OPA's website. And this report today fits very, very well within that pillar to close the mortality gap. And this report, helps us to just begin to understand a little bit better that mortality gap, and then think about different ways that different factors that go into it. In terms of this homelessness, mortality, and morbidity report, there's a couple things we want you to think about going into hearing about the data today. So this report is Illinois' first statewide population health report for people experiencing homelessness. Homeless mortality reporting has been an activity that a lot of localities or community groups or nonprofits have taken on over the last several decades, but it's relatively new for a state government to be participating in this kind of work. So there's a recent report that came out of Minnesota, and this is so this is a kind of a new trend that states are taking this on, and we're doing it because both we want it to be a resource to inform the state's programs, inform the state's policies, as well as all of our local and community partners, and then we also want it to be a tool for partners to support advocacy, to really be able to communicate public homelessness is a public health issue, and it's not kind of inevitable. There are really concrete things we can do to support the health of people experiencing homelessness, and so this report is a tool to help some of that communication. So we want to hear from you all about how this type of data can inform your work, and what would be helpful going forward. We do plan to continue. This report is kind of a baseline for us. It was the first year of this project, and we plan to continue the work looking forward. So we would love to hear from you, kind of how could this information inform your work? How could more information be supportive? And then what programs or policy actions would you like to see Illinois or other community partners take to support the health of people experiencing homelessness and to support housing access, particularly for people with vulnerable health? So the state, there are no kind of policy recommendations in this report. This is really a population health kind of surveillance report, but we are thinking about what kind of policy opportunities this report brings up or highlights, and we would love to hear your thoughts on that as well. So we will put in the chat, this is a link at the bottom of the slide to a survey where we invite your feedback on those questions and lots more details. So we would love to hear from you all what thoughts this data brings up for you. And I am going to go ahead and pass it over to Dr. Friedman. So thanks so much.
Sorry about that. I forgot to unmute myself. Okay. Okay, can you guys hear me and can you see the slides? Want to start rambling and people? Okay, great. I do see head nodding. Okay, everybody, how you doing? My name is Lee Friedman. I'm faculty at the University of Illinois Chicago School of Public Health, and I'm one of the co-authors of this report, along with my colleague, Dr. Dana Madigan, and a bunch of other people that really we couldn't have done this without. This was a very, very big team effort to get this done in less than a year, really. And we're hoping that the report will be released shortly in the next 1 to 2 weeks. We're excited for being released publicly and people can actually see the results in detail. So the report is very, very detailed. I'm just going to give a little bit of a disclaimer up front. And 25 minutes, I can't do it justice. Even just the mortality sections, I can't do it justice in 25 minutes. And I just want everybody to know that when the report comes out, you're going to see a lot more detail than what I'm going to be able to cover today. But as an overview of the mortality section for the report, so what we did is we got death certificate data and then we got hospital data. And that provided us the ability to analyze data from a mortality perspective and then a morbidity perspective. And for the death certificates, the vital records data, We analyzed pretty much every available variable that was provided to us within the database that IDPH provided our research team. So we analyzed all the demographic variables, and we provide that in great detail throughout the report. We also had 2 proxy measures for social support. While not perfect, it is really better than nothing, and I'll talk about it in detail. So we use marital status and also relationship of the key informant to the decedent, which again, I'll explain in a couple slides. We analyze data across time for trends across time, as well as spatial analysis across the state of Illinois. And because this is primarily an Illinois Department of Public Health report, most of our tables have very detailed stratification by IDPH public health regions. However, because we know the key stakeholders are the COCs and the service providers, as well as many other different types of stakeholders who would be interested in seeing the data broken up by continuums of care, that we also provide data by the COCs, stratified by the COCs as well. In addition, we provide analyses by occupation, cause of death, contributing causes of death in very great detail, as well as substance use information and toxicology data where available. So I'm going to just give a very, very quick summary of the methodology. The report has a very, very large appendix that details our methodology that we use for both the morbidity and the mortality sections. But for the mortality analysis, IDPH provided us a database that included all death certificates of decedents within the state of Illinois over the period of 2017 through 2022. Then we used different strategies to identify persons experiencing homelessness, and strategies that have been developed elsewhere in other jurisdictions in Los Angeles, San Francisco, Minnesota, Boston, and by other researchers that have published their findings within the scientific literature. And what we did essentially is we identified death certificates by keywords, homelessness keywords such as homeless, homelessness, indigent, as well as matching to known shelters within the state of Illinois, as well as identifying people that did not have a known residential address. And in the end, we identified 2,520 decedents over that 6-year period within the state of Illinois. I just want to say, we believe that there's actually far more than what we were identified, but given the limitations of the data system and our access to the data system, that this was the number that we were able to identify. Okay, so I'm just going to jump into the findings. So very consistent with prior research, what we found was that the average age of death among persons experiencing homelessness was almost 20 years younger than the general population decedents. I just want to explain that IDPH provides us all the death certificates, so our primary comparison group is the general population decedents within the state of Illinois. So when you're going to see these numbers side by side, it's comparing decedents that were experiencing homelessness at the time of death versus the general population decedents. Okay, in addition, we did identify 40 young children that had died that were identified as experiencing homelessness at the time of death, with the bulk of the early childhood deaths relating to either premature births or complications during delivery. And there's a lot of potentials for intervention from a maternal child health perspective, from a public health view, that this data then alludes to. And there'll be greater detail within the report itself. In addition, what we saw was that both the age distribution and gender distribution within the population of decedents who were experiencing homelessness at their time of death was very consistent with what's been published in other jurisdictions, in other states and regions, as well as what's been published in the literature. What we did see disparities as well by racial and ethnic disparities. While the greatest proportion of decedents were non-Hispanic white, when we actually compare persons experiencing homelessness to the general population, we saw is that there was a much greater proportion of non-Hispanic Black residents who were experiencing homelessness at their time of death compared to the general population. What you can see here is 39.6% of persons experiencing homelessness were non-Hispanic Black at their time of death, compared to 17.1% among the general population decedents. In addition, in the death certificates, there's actually a field that captures veteran status. And we know that veterans have an increased risk of both housing instability as well as homelessness. So this was a very, very important aspect that we wanted to analyze. And what we found was 10.2% of those that were homeless at time of death had a veteran status listed on their death certificate. And when we actually broke it down by age groups, we found that veterans between the ages of, that there was a greater proportion of veterans between the ages of 55 and 64 years of age among those that were homeless at the time of death compared to the general population, as well as compared to the living population. So we received data, we downloaded data from the Veteran Affairs as well as from the US Census Bureau on the general population estimates of veteran status among living Illinois residents. So another very important factor that we were interested in was social support, because we know that an absence or a lack of social support and loneliness is associated with exacerbation of psychiatric conditions as well as substance use disorders. So we kind of combed through the vital records to identify potential proxy measures of social support. So we identified both marital status as well as relationship of the informant to the decedent as potential variables that give us some indication of that social support of those that are experiencing homelessness at the time of death. And what we found was those that were homeless at the time of death had lower social support compared to the general population decedents. So what we see here is that among those that were homeless at the time of death, that 44% of decedents had never been married at the time of death compared to 16.5% among the general population decedents. And then when we looked at the relationship of the informant to the decedent, and I'll just give it a little explainer on this, is that the person that's completing the death certificate, whether it's a funeral director, a physician, a coroner, or a medical examiner, the guidance that they receive from the CDC is that they're supposed to interview a key informant who knows the decedent, then can provide truthful and accurate information to complete the information on the death certificate. And generally, the primary person that's acting as that key informant is a family member. And we see that in Illinois, the most common key informant on death certificates is a family member when we're looking at the general population. 94% of death certificates there's a family member who's a key informant. However, when we look at persons that are experiencing homelessness, only 64.3% had a family member that acted as that key informant. And both of these, again, while they're crude measures of social support, they do, again, support what we know from general research, that persons that are experiencing homelessness have far lower social support than the general population, which then is a major risk factor for exacerbation of psychiatric health conditions. Okay. In addition, in the death certificates, there is occupational information. And so the person filling out is supposed to identify what the decedent's usual job was during their life. And it's supposed to be, the guidance is the longest job held or nature of job held. So, and what we found in analyzing it was that compared to the general population, that persons experiencing homelessness, a greater proportion of them were working in general labor jobs as their usual job, primary job, and had a far lower proportion working in skilled trade jobs or professional jobs. And this is important because the literature shows that many of the risk factors and barriers to acquiring and maintaining stable housing are the same barriers that we see in both training for work as well as obtaining work, maintaining a job, as well as advancing in employment. And it impairs, and we know that persons that are experiencing homelessness have higher adverse childhood events as well as psychiatric conditions, and those act as barriers to accessing work. In addition, if you're homeless, you don't have a permanent residence, and that can make it very difficult for just simply applying for jobs. And there's many other risk factors downstream as well. And we also saw a greater proportion of individuals that were homeless that had it listed that they had never worked because of a disability. And we know that disability is also a major barrier to entering the workforce. So we had geographic information of where individuals lived and where they died. And we saw that the vast majority of individuals died in urban counties. Almost 95% of all persons that were experiencing homelessness at the time of death died in urban counties, with the bulk dying in the Westchester Department of Public Health region, which in essence, it's very close to basically mirrors the greater Chicago metropolitan area. And when we narrow it down even further, almost 60% died within the city of Chicago. Now, just by comparison to the general population decedents, only 60.8% of the general population decedents die within this Westchester Department of Public Health region, which again is the greater Chicago metropolitan area, more or less. Now, while 95% of the decedents died in urban counties, I want to emphasize, and my colleagues can emphasize this as well, that we found decedents spread out across the entire state. This is not isolated to Chicago, suburban Cook County, or the greater Chicago metropolitan area. We see that homelessness really is present across the state. And as well, when we looked at those that died within rural counties within the state, they were very, very different relative to their urban counterparts. They were disproportionately female, they were older, and they were more likely to die from chronic health conditions as well as traumatic injury, but they were less likely to die from drug-related overdoses. And that is, again, compared to their urban counterparts. Now, there's a field for place of death. Now, generally, from a public health intervention perspective, this field doesn't really help us that much, but it was a field that we used to validate the accuracy of our inclusion criteria. Again, the methodology for identifying persons experiencing homelessness in death records is relatively new, and it's only been tested across several jurisdictions. So one of our main concerns throughout the report is, are the cases that we're identifying, the decedents that we're identifying, are they individuals that were experiencing homelessness at the time of death? And so when we look at where they're dying, 24.4% of the decedents who were experiencing homelessness at the time of death died within an emergency shelter, a hotel, motel, temporary residence, or a transitional housing facility. And comparing that to the general population decedents, only 0.1% of the general population decedents died in a hotel, motel, or temporary residence. Also, when we looked at place of death of outdoors or informal settings, of those that were experiencing homelessness, 21.7% died outdoors or informal settings, compared to only 1% in the general population. So we also looked at the time trend across time. I'm just moving things around on my screen so I can actually see the slide here. I don't know if you guys can see my cursor, but the top line, the orange line, is the trend in deaths in the general population in Illinois. And the bottom line, the blue line, is the trend in deaths among people experiencing homelessness at the time of death. And what we see here in the top line, we see these three spikes right here. These are the three major waves during the early part of the COVID pandemic, when we saw those surges in deaths occurring in the general population. This spike over here was an outbreak of RSV and influenza that occurred in December of 2017 and January of 2018, just for those that are curious. And what we see among those that are experiencing homelessness, which again is this blue line on the bottom, is that we do see spikes occurring with each of the three major waves during the COVID pandemic. But more importantly is that since the start of the pandemic, we're seeing this precipitous increase in overall mortality. And what we saw is that there has been a 36.6% increase in mortality since the start of the COVID pandemic among persons experiencing homelessness in the state of Illinois. And that's actually after removing the deaths that are associated with the three main waves during the early part of the COVID pandemic. And when we look at COVID cases specifically, there were 86 persons who were experiencing homelessness at the time of death that tested positive for COVID and had it listed as a contributing cause of death on their death certificates, of which the vast majority, 76 cases, COVID was listed as the immediate cause of death. And when we actually looked at the distribution of the COVID-related fatalities among persons experiencing homelessness, 66 or 76.7% of all of the 86 deaths occurred during one of these three waves. So it's this wave right here. I'm hoping you guys can see my cursor move over these. If not, I'm just kind of moving things around. In addition, corresponding with the average age of death, we saw, again, at the very, very first slide that a person experiencing homelessness died almost 20 years younger on average compared to the general population decedents. And corresponding with that, what we see is that the proportion of persons experiencing homelessness that died from chronic health conditions, such as diseases of the circulatory system, respiratory system, and other conditions, there was a lower proportion among those that were homeless at the time of death compared to the general population decedents. However, what we saw was that there was a much larger proportion among those that were homeless at the time of death that died from injury and poisoning, whether it's a traumatic injury and primarily for the poisoning, most of those deaths were actually drug-related overdoses, but we did see deaths as well from agents that are not associated with substance use disorders that resulted in a poisoning-related death. And we saw a dramatically much higher proportion of homicides, pedestrian-related injuries, as well as excessive cold-related injuries. And you can see these proportions here. So just a little summary, just to read this, 32.9% of all persons who were experiencing homelessness that we identified in the death certificates died from a drug-related overdose, compared to only 3.4% in the statewide group of decedents. Just going to pause for 1 second so people can stare at this. And again, I believe the slides are going to be made public as well, in addition to the report. So corresponding with the substantially higher proportion of drug-related overdoses among those that were experiencing homelessness at the time of death, we were able to analyze toxicology information when it was available in the death certificates. And we saw that 38.1% of those that were homeless at the time of death tested positive for any drug that is associated with a substance use disorder, compared to only 4.9% in the general population. And we saw the full gamut of substances that are typically found in the toxicology screen, including alcohol, opioids, stimulants, sedative, hypnotics, anxiolytics, and others as well. And this is provided in detail within the report. So in addition to the disproportionate number of decedents testing positive for drugs associated with substance use disorders, when someone did test positive for a drug, they were also more likely to test positive for multiple drugs at the same time. So we actually saw that 15.8% of persons experiencing homelessness tested positive for 3 or more substances in the toxicology screen, compared to only 1.2% in the general population decedents. And specifically among those that tested positive for opioids, second here, I'm just playing shift around here, that of those that tested positive for opioids, 37.1% of these individuals tested positive in addition to another agent that is known to increase the risk of respiratory depression or sedation when taken in combination with an opioid. So, from a public health view, there's 2 primary pathways that contribute to the observed substantially younger average age of death among those that were homeless at the time of death. Again, remember, there's about 20 years younger among persons experiencing homelessness compared to the general population. So it's in part contributed by the fact that there is substantially higher substance use disorders, as well as comorbid psychiatric conditions among persons experiencing homelessness. But in addition, the circumstances of unstable housing and homelessness really brings together and concentrates risk factors related to social, economic, and nutritional risk factors, which has been shown to increase the risk of earlier onset of disease of these chronic health conditions, as well as exacerbating chronic health conditions once a person is diagnosed with them, or it's recognized that the person has that condition. I think a really good example, because it's such a common condition, is diabetes. That with diabetes, if you do not have a home, it is very difficult to store your medication, keep it out of sunlight, as well as maintain a regimen to adhere to your medication, and to do blood glucose testing without electricity, to charge the blood glucose devices that you can put on your finger or whatever you're using for testing your blood glucose. So simply the conditions of being unhoused really exacerbates the ability to adhere to a medical regimen to keep and manage your health condition appropriately. The good news is that research shows that early access to psychiatric and general health services, as well, and of course, housing programs, which is key and essential, is associated with a reduction in morbidity and mortality in persons experiencing homelessness. So there are definite pathways and avenues for intervention that can be done, and a lot that we can learn from this report itself as well. So as I mentioned, I can't do this report justice in 25 minutes. My colleague's going to jump on now right after me, but I just, it is a very comprehensive report, and we're looking forward to people's feedback. But I just want to highlight other aspects in the report that I couldn't cover today. So we do go into detail on decedents, persons experiencing homelessness who lived in rural counties. Throughout the report, we provide information on racial and ethnic disparities, as well as we identified interesting subgroups such as widows, foreign-born decedents, as well as mechanisms of injuries, such as homicides, suicides, cold-related injuries, drownings, and pedestrian-related injuries, and as well, we have a comprehensive section on detailed drug-related overdose data. So I'm going to hand it over now to my colleague, Dr. Dana Madigan.
Okay, I hope you can see my screen and hear me okay. I trust someone will stop me if you can't. Now we're going to transition a little bit into the morbidity analysis. And we think it's really important that this goes hand in hand with the mortality analysis, because if we want to work at closing that mortality gap, we also want to look upstream and see where there might be earlier points of intervention and what the health landscape is, before we get to the death certificate data. Okay, so we're going to kind of cover the same topics that Lee did in a similar order. We'll go through some demographics, the geographic distribution and temporal distribution, primary diagnosis and comorbidities, injuries, and also severity measures. Briefly, the way we collected these cases is a little bit different than the mortality data. So we used the Illinois discharge data. This includes inpatient and outpatient, which is basically hospital admissions and emergency department visits, with a few other points of data that are collected. And we did this for 2017 through 2022 full calendar years. We used a billing code, an ICD-10 diagnosis code of Z59, which indicates that somebody is experiencing homelessness, to identify the people. And then we also pulled in that time period any other visits, during that time period, whether or not they had the Z59 code. And this was all provided by IDPH, and they worked really hard to get this to us. And so we're really appreciative of that. What we don't have in this data that we had for the mortality data is a direct comparison to the general population. And that's okay. We still have a ton of information here. And so I just want to highlight that we kind of worked through and identified the people that were experiencing identified as experiencing homelessness in this time period, pulled all of the records during that time period, and some of them will have this code and some of them don't. And so we present the data as, the total for all of the visits together, but then we also present it by whether it was an outpatient or an inpatient visit, and whether the visit was contained the code for homelessness or whether it didn't. And a lot of times these align, but there are some key differences that we'll highlight throughout. And when you have access to the report, you'll be able to see these different categories across all of the data that we provide. So as you can see, we were able to identify a large number of hospital visits during this time. And only about 12.6% of them had the Z59 code at the time of the visit. And so you can see the majority of them are these outpatient emergency department visits, about 3/4, and then admissions, and you can see the breakdown there. So the majority of visits were for males across, all the categories, and that was even higher amongst those with the Z59 code. Almost 3/4 of the visits were for males. They were predominantly for adults aged 25 to 64. However, we do see a good number of visits for youth under 18 years old and for adults 65 years and older. The large majority, over 95%, were for people identified as Illinois residents, and almost 10% of the visits were designated as self-pay, which meant there was no known insurance coverage. And this, we know from other research, has really decreased since the implementation of the Affordable Care Act. However, that's still a large proportion of the visits that don't have insurance coverage. The majority of visits were for non-Hispanic whites and Black African Americans, but this proportion varied by visit type and coding status. So non-Hispanic whites, accounted for more admissions that had the homeless code, and Black African Americans accounted for more of the emergency department visits, outpatient visits with the code. And similar to what Colleen said in the introduction and what Lee has highlighted, this highlights a disparity, the rates at which Black or African American Illinoisans experience homelessness, as well as these hospital visits, are really disproportionate to what would be expected for the population distribution throughout the state. We also saw that the greater Chicagoland region represents a large majority of the visits for people experiencing homelessness, over 50%. And this is true across whether we're looking at IDPH regions, if we're looking at COCs, continuums of care, or if we're looking at the EMS regions. And the majority of visits occurred within urban counties throughout the state. However, similar to what Lee wanted to emphasize, there were visits identified in every region of the state by every geographic breakdown that we presented, and even at each sub-stratification with visit type and coding status. So for the temporal distribution, we did not see the same kind of trend that Lee did, related to the COVID pandemic, or discernible trends by year or day of week. However, we did see some seasonal variations. So the proportion of hospitalizations with admissions peaked in August, and emergency department visits in the cold weather months, so like November to January. The top primary diagnosis for admissions was mental disorders, and for the emergency department visits, it was identified as symptoms, which is kind of a non-specific diagnosis code. Other common primary diagnoses were musculoskeletal and connective tissue disorders, drug use, and alcohol use. And the top 6 categories of comorbidities, there's an Alex-Hauser comorbidity index that we use to group ICD-10 codes, and across the visit groups, these were consistently drug use, hypertension, alcohol use, psychoses, chronic pulmonary disease, and depression. And so you'll see, even in these top conditions, chronic diseases represented, but if you kind of dig deeper, you'll see that there's a lot of different chronic diseases and infectious diseases that are affecting this population. Then when we look at number of comorbidities, using that same scale, we can see with admissions that there's, on average over 3 comorbidities per visit listed, and emergency departments are just 1 or more. And then the proportion or percent of patients that have 3 or more comorbidities, again, is much higher in the admissions, where we're, above 60%, where in the emergency departments, we're looking at like 10 to 15%. And the admissions were also much more likely to have a higher prevalence of nearly every comorbidity group, including those representing severe conditions such as some cancers and other conditions. And one thing to note with this is, an admission is likely to be like a much more comprehensive health record, and they have more time together, the health histories and the full spectrum of information. So this doesn't necessarily mean that these individuals do not have additional comorbidities. This is just what's captured in the billing record at that time. Approximately 15 to 20% of the visits were for injuries. These were most commonly poisoning, falls, assault, homicides, temperature-related, and transportation-related injuries. And for transportation-related, they were most often pedestrians or bicyclists struck by motor vehicles. There were almost 30,000 visits from assaults. This was seen more commonly in the emergency department visits, and over 15,000 visits resulting from suicide attempts, and this was more commonly seen in the admissions. Again, that might be kind of subject or relative to common clinical care pathways for these types of conditions. Cold injuries were 10 times more common than heat injuries. And heat-related injuries were more common in emergency department visits, and cold-related injuries were more likely to be admitted. This might seem a little bit in contrast to what we saw with the seasonality data, but there could be a lot of reasons for this, like with increased respiratory infections in the cold weather months and other factors just besides temperature-related injuries driving those seasonality patterns. Substance use disorders consistently appear as a top primary diagnosis, comorbidity, and cause of injury. Over half of visits note that the patient suffered from substance use disorders, and just over 10% are coded for intoxication at the time of the hospital visit. The most common agents cited are nicotine, alcohol, stimulants, and opioids. And intoxication is underlined here because that's correlating with these two agents that are underlined for being commonly involved in the visits. Poisonings are caused by a variety of pharmaceutical and non-pharmaceutical agents, including those associated with substance use disorders. Almost 5% of visits involve poisoning. They are more likely to result in admissions, and common agents include narcotics, psychodysliptics, other psychotropic drugs not otherwise classified, diuretics, and anti-epileptic, sedative, hypnotic medications. In terms of severity measure, the total cost billed, so this is not necessarily what was paid, but just what was billed in the hospital records, was over $16 billion for this time period in 2020 US dollars. The median bill per visit, regardless of the code, was about $19,000 for admissions and $2,500 for emergency department visits. Of the admissions, the median length of stay was 5 days, and half of visits fell between 3 and 7 days, and about 3% required mechanical ventilation. The majority of discharges across visit categories were routine, generally to home or self-care. This is slightly higher in visits coded for homelessness using that C59 code. It's also higher in emergency department visits. And similar to what Lee was saying, we know this is a barrier to appropriate continued care or treatment. The amenities that are available to support continued care and treatment for stably housed individuals may not be available to people experiencing homelessness. And so since that was all at the visit level, it's hard to say is, 1 or 2 people really driving a lot of this, or what's the breakdown here. So we also did a brief unique patient level analysis that we hope to build on in the future. But essentially we use that same data. So it's the same number of visits, everything is the same. And we were able to identify over 60,000 unique people. There was a median of 14 hospital visits per person. Again, this is over the 6-year period, not just in 1 year. And the 75th percentile of users had 27 visits in that 6-year period. The demographics and health issues in the hospital cases, both at the visit level and the unique patient level, is nearly identical to the decedents. So, you know, similar people are being identified using this methodology to identify cases in the hospital data and vital records. Again, we know that this is likely very incomplete, but I think we can see there's a lot of information to be gained, you know, regardless of that. And then more work needs to be done to identify like who is being coded and when, and what are the populations that might be being captured, and then those that are maybe more likely to be missed. And then in terms of utilization, this figure is basically during the years a person is identified as experiencing homelessness using that code, their hospital utilization increases substantially. So on the left here, you can see the mean number of emergency department visits, and on the right, admissions. And then the darker blue bar is the number of visits if a person had a code for homelessness that year, and then the number of visits if a person was not coded that year. And so you can see a substantial difference between the two. This is the link that Colleen sent in the chat, and so we, you know, welcome comments and insights related to this. And then I think I'm going to stop sharing and let Colleen take back over.
Thank you so much, Dr. Madigan, and thanks everyone for your attention and your questions. We have been working our way through them on our end. So let's see. I think I'm just gonna work my way down here a little bit in the order that they came in. And I know one question was, will we form a policy committee to build on this work? The department is considering kind of what the process might look like going forward to take on some policy commitments related to this data, but as the initial step, we're certainly really welcoming people to fill out this feedback survey. We are thinking kind of, you know, over the next few months about what would priority actions be to kind of build on the work that IDPH and partners already do in light of this report. So as an initial step, I would really welcome you to take the feedback survey and express your interest in. There is a field in that survey that asks, you know, if you're interested in engaging further with the department around this work. So would really welcome folks to express interest that way. And we're continuing to think about what process might be going forward. Jenny, anything you would add?
Sorry, 1 second. I was let me put my video on. No, I think you know, I think we really are interested in people's feedback on this report and thoughts on next steps, just to kind of gather where we're at. So please, you know, add any thoughts you have on that at the survey link that Amanda just put it in. We will also, just another thing too, we will be sending out an email following this webinar with all the resources that were shared in addition to the link. So if you haven't caught it in the chat, don't worry, we'll make sure you get that in the follow-up email.
Wonderful. And then I think we got a lot of great questions related to the mortality section and death certificates specifically. So I think some of these we'll be able to dive into, and some we might need to get back with folks. We want to make sure we're getting you correct information. So a first question was, do Illinois death certificates have a homeless specific flag, or did the report rely on PEH related keywords alone? So Illinois death certificates don't have a homeless specific flag, but Dr. Friedman, do you want to talk a little bit about, I know the identification process was a little bit more detailed than, you know, just keywords.
So we really use this multi-pronged strategy to identify cases. Hopefully you guys can hear me. Otherwise you just see me talking. But we did use keywords. And I just want to say that there's actually this several HUD and several other organizations actually have generated these very kind of like large master lists of keywords. We used them all. However, what we found was that the vast majority of both phrases and keywords that were in these lists are never used on Illinois death certificates. And that's because there's a lot of variability across jurisdictions and even within jurisdictions when it comes to completing death certificates. So, when you see between, let's say, Illinois jurisdiction versus California or Minnesota, you'll see a variability in the types of phrasing that's used. But also within a jurisdiction or even within a county, you'll see that whoever's filling it out, whether it's the funeral director, the coroner, medical examiner, or a physician is filling out that death certificate, they're using different terminology as well. So we really went through this refining process. But in addition to using keywords, really we're about 90%, or actually a little bit over 90% of all of our cases were identified was through two main avenues and strategies. One is they matched their residential address to a known shelter in the state of Illinois. That was about 45%-ish. I don't want to give a wrong percent, but it's in that zone where identified those individuals matched to a known shelter that provides housing services. And then the next big group, about, again, 45%, did not have a known residential address. And this was a strategy that was developed by other departments of public health. And, it still needs to be further validated. But again, it looks like when we look at the characteristics of the decedents that we did identify, it aligns very, very, very strongly with all these other reports that have used this strategy, but also just the broader peer-reviewed scientific research that has evaluated persons experiencing homelessness. So it's consistent. There's a face validity to the process and procedure that we use. So really, keywords was only a small fraction. There are jurisdictions that have started implementing checkboxes for homelessness, but that has to be done at the local level. As I understand it, I know the IDPH folks can probably add on to this. CDC sets the guidelines for death certificates. So if there is going to be a change to it, you would have to go through probably some process in order to modify the death certificate.
Yes, and we do have someone from our Division of Vital Records who just joined us, Megan Clark Jimenez. So she is available to answer a lot of these the cause of death questions, as well as the issue that you just brought up. So Megan, if you could you just, and make sure that we can hear you, but actually you should have joined as a panelist. Let me see. Can you unmute yourself, Megan? Okay, she's not able to unmute. So we will have Megan join. We have some technical difficulties, but yes, Lee's correct. The cause of death on a death certificate and any field on a death certificate is not determined by the state. It is determined by our federal partners. It is a process to go through. However, there's, Megan, are you?
Hi guys, can you hear me?
Great, yes, you're the better person to talk about this than me, so why don't you go ahead?
Sure, yeah, no problem, and it's not, there's no video, but that's okay. You probably don't need to see my face for this. How's everyone doing?
Great, we've got a great group on here, about 175 participants.
Okay.
So lots, yeah.
So was the question, I think I kind of came in during the middle of it, how cause of death, heat-related or weather-related cause of deaths are determined?
Yeah, we have a couple questions. I think the first question, I think if you could provide some general background, is how are the fields on a death certificate determined, particularly as it relates to cause of death and the different cause of death fields that are available?
Yeah, so there's the underlying cause of death and then contributing factors. Looks like there's a comment, homeless at time of death checkbox, maybe that's not related. So we also have other contributing conditions, which is in a separate box, but how coroners determine what cause of death is going to be listed, they probably received that training from in Illinois, there's an Illinois Coroner's Training Board. So like from a vital record standpoint, you know, we assist coroners with completing the cause of death and certifying the record either via fax attestation or using the IAVRS electronically. But we don't really give guidance on how to determine cause of death. If that makes sense.
Okay, so that would be, yes, that would be determined through the training that coroners receive that is not provided by IDPH.
Correct.
Okay, great.
So Megan, maybe I can just add, you know, there's a lot of research showing that the primary cause of death, immediate cause of death fields, they're problematic because it really does vary by the person completing it. So for this report, we avoided using the primary cause of death throughout the entire report. We basically treat all listed contributing causes of death in the analysis equally because of that variability that's been shown in research. So we do not report primary cause of death in this report, except in very, very specific circumstances. And in those circumstances, we note that we're using it. In all other circumstances, we're using contributing cause of death only. Okay. So that does alleviate, because it is difficult, right? There's a lot of examples in the comments about what do you do if someone, you know, dies from a cold-related injury, but they also have diabetes, you know, so we're basically reporting both.
Let's see, I'm trying to see what our other kind of death certificate specific questions are. Did we talk about kind of weather already and how that is typically reflected on death certificates? Okay, so another question is, when will the extreme heat and very frigid weather factors be made more prevalent in the determination and death? Often it is labeled as a possible contributor, but not the cause. I don't know, Jenny or Megan, do you have any thoughts about that?
I mean, so again, I think we're talking about determining cause of death. I don't think that we advise the coroners on how to determine cause of death, rather how to indicate that on the record. So if there is something going on to better that data, that probably would be a question for the Coroners Training Board or the Coroners Association.
And I think just to add to that, so for deaths that could be weather related, you potentially have something like an underlying factor. So let's say cold. So an underlying factor would be exposure to excessive cold, you know, nature of cold weather, and then you would then that would go to hypothermia. So then it goes more towards the actual cause of death, the contributing factor. So the weather would be an underlying cause or contributing factor to that death. This actually just came up in an email exchange we had last week about this exact issue. Definitely something that is a topic of conversation and to look further into to see how we can better track and collect that data.
Wonderful. And then another question is how often drug tests are completed on individuals that after they're deceased, which I know kind of varies by locality.
Yes.
Yeah.
Yeah, so that does vary by locality. It also has to do, we have a project that we work with Northwestern School of Medicine. They collect data on death investigations for people who have experienced an overdose. So in those instances, people who have experienced an overdose, there is a full panel, toxicology panel done. The initial panel done by a coroner or medical examiner does vary by county. That is something that we can look further into to get an idea. I am hearing differing opinions just in what I hear if it's done in every single county by every coroner versus not. So we're going to look further into that. But I do know that if someone is passes away, dies of a suspected overdose, there is a more intensive investigation done, and that data was used for this report. So it's called SUDORS. That data was used to inform the mortality section of this report. And we as a state are also very interested in that panel of substances being tested for, because that does allow us to get an idea of the merging substances that we're seeing that are contributing to overdoses in our state.
Wonderful, thank you. Let's see. And just staying on death certificates, and have we talked about, so I don't have, when there are several factors contributing to a death, just thinking through how is a chief factor determined? I think we've touched on that, but anything else you all would add?
I mean, I think what it's telling me is that there's a lot, and these questions about death certificate and determination of death have come up on other calls that I've been on. I think it's an opportunity for us to potentially have more information out there about how cause of death is determined.
Let's see. And then Dr. Friedman, is there anything, we had one question in terms of, is there any way within this data that we could identify college students among decedents, maybe on occupation? I don't know if you saw that come up as an occupation.
So there is a student option within occupation that's available. We didn't see sufficient number of cases to list it. So we could then, like, you know, use age to filter out like general age for college age individuals, and then identified by students, but we did not see a sufficient number of cases.
Thank you. Let's see. Okay. In terms of thinking about the morbidity data a little bit, Dr. Madigan, one question was, were you able to understand anything about the type of assault or more information about assaults resulting in the need for care? For example, could you kind of parse out stranger assault, sexual assault, domestic violence, anything like that within the data?
Yeah, so we're limited to the ICD codes, and that there are injury codes. I don't think it's classified quite in the way that's being asked, but we do have more information in the report on, you know, if like the assault was with a firearm or other information with that. Again, this was more exploratory, and there's probably a lot of subgroup analyses that we could dive, you know, further into and see what we could glean. But I don't believe in the report we grouped it, you know, quite in those terms. There is more information on the assaults, and that I'll make a note that that's definitely something of interest, I think, from what I'm hearing for future reports.
Thank you so much. Yeah, I agree. Another question in terms of the morbidity data was, do you happen to know if people experiencing homelessness, once coded with a Z59, if an EHR platform will flag those individuals as homeless, and other folks using Epic or NextGen would be able to see that flag?
Yeah, that's a really good question, and something we're actually actively trying to parse out a little bit right now. Essentially, there's in Epic, I can speak to an Epic. I know there's a social determinant screen that might flag for that, and potentially other providers can see that and, you know, allow for some, you know, continuity of care concerns or things like that. But we're not quite sure. Part of what we're looking at is not only who gets coded, but where this gets entered in the EHR, and then what kind of implications that has. So we're working with our hospital system here to try to kind of do a deep dive into how it's being identified, coded, who's coding, when, where, and then, you know, some of those other follow-up questions might be able to be answered, you know, like if another provider can see it or things like that. So it's definitely an important question, and one that I think we're all trying to come up with a more definitive answer to.
Yeah. Thank you so much. And I know another question was related to for folks experiencing homelessness statewide, what percentage of folks are unsheltered versus in shelter. So the statewide data source we have is the point in time count, which is a yearly kind of snapshot on one day in January. And there is kind of sheltered and unsheltered information in that, as well as a variety of demographic sources, demographic information. So you can find that information at a high level in the Home Illinois report, which I've just put a link to in the chat, and more information on HUD's website, which I can also link to. Let's see, we know that in 2022, on the day of the point in time count, 10,431 people were identified. Oh, I'm sorry, that is 2020. In 2020, 10,431 people were identified. About 8,000 of those were in shelter, and about a little over 2,000 were unsheltered. And then in 2022, the data was similar. But I will put some links in the chat where you can find more information. Let's see. Okay.
Kevin also shared some recent numbers. So thanks, Kevin.
Yeah, thank you, Kevin. Okay. I know we had a question in the chat about race and ethnicity on death certificates. Let's see. Mortality. Oh yes, okay. Thank you. The question asker said, thanks to all for conducting this important work. We are doing some similar work here in Toronto. Questions about ethno-racial identity. Is this information recorded on the death certificate, and is it a mandatory field? If not mandatory, how complete is the field? How is someone's ethno-racial identity determined? Is the information provided by next of kin? Dr. Freeman, I don't know if you have any thoughts.
It was highly complete, and there are specific categories that are preset on the death certificate that conform to, there's actually a congressional standard for identifying race and ethnicity, and it conforms to that. So those categories align with that congressional and executive standard. So yeah, it is on the death certificate, and it was very, very highly complete. I want to actually give you the level of incompleteness, so I was running to kind of pull up the table, so I can provide that in the chat in a second, but it's low.
Thank you. Let's see. I'm trying to see what else we haven't gotten to. And okay. Yeah, I know there are some general questions about ways this data, has been used, and what we're hoping to do with it. I think, really generally, this is a brand new project for the state, so we are just beginning to let it kind of shape our programs. But we have seen in other places that this kind of mortality review can inform work and advocacy in a wide variety of ways. And I don't think, let's see. Yeah, so in terms of what IDPH is planning to do with it, IDPH does have several other activities, that are part of Home Illinois, activities thinking about, overdose prevention for people experiencing homelessness and other actions. And, we know more work is needed. And so we're excited to have this data to inform some of that work, and are also socializing it with colleagues and the state Department of Human Services, who work on overdose prevention and a wide variety of other programs. So I think We are actively working on, making sure this data is informing policies and programs, but we are in the beginning stages of that. And yeah, we really are interested in being in conversation with localities and community orgs on kind of how this data can be most useful to them, and what kinds of additional information would be actionable. Let's see. Yeah, so I think those are kind of general thoughts on what we're looking to do with it. Let's see. I'm just looking through to think about what we've missed here. And I know somebody asked in the chat if we could share again the data sources for both the morbidity and the mortality, and if this data came from IDPH syndromic surveillance data. Could folks just confirm the data sources for both sections again?
Yeah, we received data from the Illinois Department of Public Health from the vital records, all the death certificates of decedents within the state of Illinois for the mortality analysis, and then for the morbidity analysis, again, data from the Illinois Department of Public Health is Illinois comp data, which is almost a census of all hospital visits within the state. Depending on the year, it runs around about 97% of all hospital visits are captured within the comp data, and that is ED visits or outpatient data as well as admissions. Those were the two primary data sources we use. For denominator data, we use point in time data, and then we use Richard's methodology to estimate double death. That'll be the report as well.
Thank you, Dr. Friedman. And I know Jenny posted in the chat some links to learn more about the data sources. So thank you, Jenny, for doing that.
And I think just for a little, I think for those that aren't aware, syndromic surveillance is basically emergency room. It's basically a real-time feed from emergency room data. The data that we use for this report is hospital discharge data, which includes emergency room data, but it is more finalized data and applied to the ICD-10 codes, which are the diagnosis codes. So I know not everyone's familiar with the different types of data sets.
Thank you so much.
And just real quick, I'm so sorry. The link I put in there about SUDORs, that is just to provide people additional information on the program, which is the statewide unintentional drug overdose reporting system. And this does come from coroner reports. That is again, a death investigation, and they do a much broader, comprehensive tox panel. And so that is the data that did a lot that Dr. Friedman used in this report, and just gives you an overview of kind of what the process is and that data. And just to reiterate, a lot of this does vary county by county when it comes to the tox panel, and the SUDORs program does a lot of training and technical assistance with coroners as a part of this program, which is funded by the CDC. So not all counties are participating in the SUDORs program. The vast majority of Illinois counties do participate, but that is one of the best ways that we get some of this rich data around deaths due to overdose.
Let's see. So I'm gonna invite any final questions. I think we've worked through those that were on our radar. So really want to thank everyone for your questions and your attention, and to all of the presenters for your work on this webinar. I think we also want to acknowledge that, you know, we understand that this is really heavy data, and many of you are kind of on the ground experiencing homelessness, working to prevent and end homelessness every day. And so just want to acknowledge that for many folks that this data is probably, you know, not surprising, and just a kind of a reflection of the really difficult realities that you're contending with day to day. And so IDPH is just very grateful for everyone's partnership as we move forward on this project, and really want to recognize that we see ourselves as, you know, having a role to play in this work, but really just working to kind of, you know, be useful and be good partners in all of the important work that many of you are doing every day. So thanks to all of you. And I see a question: with all payers claims data used as a part of the ICD-10 code analysis? Dr. Friedman, would you know, or we can follow up as well? Oh, sorry. That was a question for Dr. Madigan.
So it's fine. I'm not entirely sure what if all payers claims data is a specific data set, or if you're referring to it meaning it's inclusive of all payers. But like Dr. Friedman said earlier, this is a capture of probably 97% of all hospital visits in the state, and that data set is not limited by who the payer would be. And Tyler, it sounds like you're doing a lot of similar work in your state. So I'll drop my email in the chat. And if you want to connect, you know, on more specific methodology or things, you know, we're happy to do that. Oh, thanks, Dylan. I don't know if somebody from IDPH wants to answer if that's how Illinois is set up as an APCD or not.
I don't know if that's the acronym that's used, but we do collect data from all payers, and that is one of the, you know, we can see how all individuals, the payer of their care through the hospital system, through our hospital discharge data.
Wonderful, thank you both. I am dropping my email in as well, and as you all can see, if it's depending on the specifics of your question, I may pull other folks in to connect as well, but I am more than happy to follow up with anyone about this report or questions that it brings up for you. And I'm going to drop the link to our feedback survey. And again, we will follow up with everyone who was registered today when the report is out this month, and share the slides, share the recording, you know, all those other pieces, and have them online on IDPH's website soon. So I think we can go ahead and give folks a few minutes back. Really want to reiterate our thanks for your engagement and continued partnership around this work. Anyone else? Jenny, Dr. Madigan, Dr. Friedman, Amanda, Megan, anything you want to say before we close? Okay. Thanks so much, everyone.
Yeah, thank you all again. Thanks for your great questions. This is all really helpful as we continue this work and look towards the next year and how we can even improve what we've done so far. So thank you all so much. And just reiterate what Colleen said. Thanks for attending, and you know, we'll use this to move the work forward.
Thanks, everyone.